Okay, we are ready to go.
Okay, so good evening, everyone, and welcome to the May 8, 2025 meeting of the Health and Environmental Committee. My name is LV Barroso, and I'm the chair of the committee. Tonight, we are joined by Assistant District Manager Brendan Burt. This meeting is called to order at 6:34 p.m. And as a reminder, New York State law requires all committee members who are not able to attend the meeting in person to have their names on and their first and last name displayed from the time the meeting is called to order until the time the meeting is adjourned. Members of the public, you are attending virtually. Who are attending virtually, you can raise any questions or comments that you have through the Q&A feature of Zoom. Members of the public who are here in person, you can raise any questions that you have by raising your hand. If there is time following the committee's discussion, we will field questions from the public. In tonight's meeting, we need a minute recorder. So anybody present who volunteers to take the minutes tonight? Brandon, on the list.
Yeah, do we know who's
Do we
already
have
done?
any member?
Yes, so I'll share who has most recently done it. Just a moment. Screen. Okay, so these are the people who've most recently done it.
I volunteered last Thursday and I'm
Yeah,
gonna be fighting with those minutes.
Yeah, you volunteered for the public safety.
So I can't do 2 minutes at the same time.
Yep, somebody has to do this.
I can do it. I can do
Okay.
it.
Okay.
All right, so Gloria,
Miriam will do the minutes.
huh?
Miriam will do the minutes.
Okay, thank you so much, Gloria. So Gloria will take.
Miriam.
That's a name that gets confused a lot though. I don't know why.
Yeah. Miriam will do the minutes.
Okay, so we will now take attendance by roll call, and Brendan will conduct the roll call.
Committee members, I will call your name. When your name is called, please say present. I will announce if there is quorum. Elvie Barroso.
Present.
Marty Barrett won't be with us tonight. Barack Friedman.
Present.
Rupal Kakad also won't be with us tonight. Neither will Kevin O'Keefe. Marion Robb.
Present.
Mubin Siddiqui will be present later. And Gloria Haig.
Present.
We do not have quorum.
Okay, so the agenda for tonight's meeting was distributed ahead of time by the board office and is reflected on the screen before you. So note that the order of the first two agenda items switch from what you were sent ahead of time. If there is no objection, we will adopt the agenda as presented on the screen. Members of the committee, if you object to adopting the agenda, please raise your hand. So seeing no objections, the agenda for tonight's meeting is adopted. So the minutes from the March 13 meeting were distributed ahead of time by the board office. If there is no objection, we will adopt the minutes as drafted. Members of the committee, if you object to adopting the minutes, please raise your hand. And seeing no objections, the minutes from the March 13th meeting are adopted. They will soon be available on the CB6 website. So in order to conduct the meeting efficiently, let's observe a few ground rules. No one may speak until granted the floor. Committee members who are here in person, if you have questions about the committee business or wish to make a motion, please raise your hand and I will identify you so you can speak. Committee members unable to attend in person, if you have a question about the committee business, you may raise your hand through Zoom and I will identify you so you can speak. All committee members, it is extremely important that only one person speak at a time so that members of the public watching at home can understand what is being said by each committee member. The chat function for committee members present by Zoom should not be used for committee business or questions about agenda topics. All such remarks should be made on a record by raising your hand through Zoom. Chat should only be used to alert us to any technical difficulties you are having or to state in writing information that was already stated aloud on the record during the meeting. Tonight's agenda is, the first one is the discussion of the Harness Expertise of Licensed Professionals Act. And our presenter for tonight's meeting is Mr. Jose Miguel Juarez.
Healthy.
Yeah.
Sorry to interrupt, but wasn't Senator Clement Siegel's office going first?
Oh, I am sorry. It's
Yeah, they can only be on
Evan.
until-
Is it Evan?
Yeah,
Yes.
Oh,
they can only
Okay,
be on
so-
until 7, so sorry about that.
sorry about that. The discussion of the Harness Expertise of Licensed Professional Act will be presented by Mr. Evan Lieberman from the Senator Holman's Seigel office.
Great. Okay, so I can take that as my cue. Yeah, I'm Evan Lieberman. I'm Assistant Legislative Director for Senator Holman Siegel, who, as you all may know, represents the west side of Manhattan in the state Senate. So, I was asked to discuss what we've called the HELP Act, which is a bill that was introduced in the New York State Legislature, and parts of which just passed yesterday as part of the New York State budget. So, I think I'll discuss three general things, which is what the bill does, two, how the budget incorporates and doesn't incorporate the bill, and three, what sort of things we're looking at going forward. So general background for the bill is that there are, as I'm sure many of you know, many ways that the law allows for people who need it to be involuntarily hospitalized, and there is a legal standard for this to happen. And in the many situations in which this could happen in the various institutions, generally at some point, whether in the beginning or after a certain amount of time, the person needs to be evaluated by people with the right qualifications to determine whether this person meets that legal standard. Currently, the law requires that only a psychiatrist, or in certain circumstances a physician, can make that determination at various stages in this process. Through conversations with New York City and their hospital system, one of the arguments they've made is that the difficulties of this process, in addition to the lack of beds that New York City has, is a result of the fact that there's a shortage of people qualified to make this determination that someone is in need of involuntary hospitalization. What the HELP Act does through those conversations is expand the set of people qualified to make that determination to include, in addition to a psychiatrist, a psychiatric nurse practitioner, a psychologist, and a clinical social worker. And again, the thought behind that is one of the causes for reasons why people who might need involuntary hospitalization that don't receive it is because there aren't enough qualified professionals to make that examination. And another reason why institutions may lack certain beds, according to New York City, is that they don't have enough qualified examiners. So this bill seeks to fill that gap and hopefully ensure that more people who meet that status and are in need of temporary involuntary hospitalization can get that treatment. So that's the bill. It runs through the various scenarios in which involuntary hospitalization is justified, but that's generally the idea. The budget incorporates part of this, so it expands the qualified examiner to include psychiatric nurse practitioners, and it also, which our bill does not do, changes the underlying standard of that is used to evaluate whether someone is in need of involuntary hospitalization. The budget also, and I think this is, we can all agree, a good change, incorporates changes that the HELP Act proposed to discharge planning to ensure that the hospitals that involuntarily can hospitalize someone then coordinate more with whomever that person might have been working with in their community when they are planning on discharging that person. So ensuring that they give notice of discharge, help make the discharge plan in collaboration with the community-based provider that person might have been working with, and ensure that the community-based provider receives a copy of the discharge plan and receives notice of discharge and receives notice upon involuntary hospitalization. There are a lot of other good changes to discharge in the budget, but I think that is the way that it connects with the HELP Act. So I'll leave it at that. And then, the final thing is, so, what can we do going forward to ensure that people who we know or might see on the street who may be in need of temporary involuntary hospitalization or other sorts of treatment or examination or receive that? And I think that one area that was isolated for us through work with the district attorney was ensuring that those who are determined by judges and after examinations unfit to stand trial and have the charges against them dismissed are referred to the sorts of assistance such as a caseworker or other programming to ensure that when those charges are dismissed and they're released back into the community, they can receive the support they need to not only not reoffend, but to actually be a functioning person in society. And of course, just general background on that is currently under Section 730 of the criminal procedure law, if someone, say, for example, steals something and is charged with a misdemeanor and comes before a judge, there's a process through which this person can be examined and deemed by the court unfit to stand trial. And, obviously there's a examining standard to determine that. And under the status quo, a big problem is when someone gets that designation, the charges against them are dismissed. And while they can be hospitalized for up to, I believe it's around 60 days, that doesn't necessarily ensure this person receives the consistent help they may need. There are a lot of instances in which, the most prevalent instances are when we see when we see a crime committed by someone who was having a mental health crisis. There have been many highly publicized instances in which that person had a prior 730, as they call it, in which they were deemed unfit to stand trial and had their charges dismissed. So, we think that specifically referring people to what are known as CTI teams and single point of access, which can help someone access benefits, ensure that they're receiving treatment and following their treatment plans, as well as help them access housing. That we can, the bill ensures that someone who receives a 730 is referred to a CTI team and to a single point of access by the hospital that is temporarily holding them prior to discharge. So, when they're released back into the community, they will receive the services I think we would all agree they need. So hopefully that gives a sense of what the HELP Act is trying to do, what the budget does related to the HELP Act, and what other legislation we're working on to address this. And so I can give you guys the bill numbers for all that in case it would be helpful to, after this, go back and actually read the text. But I think I'll leave it at that. And I'm happy to clarify anything I said or take any questions.
Yeah, that would be great if you can give us those so we can review.
So the second bill I mentioned about section 730 is known as the Support Act, and I'll send the link. And the Help Act is,
Yeah, Evan, I have a question.
yeah.
So when it comes to the monitoring, who does exactly the monitoring of treatment?
In a hospital setting, or in an inpatient setting, or in
No, in the outpatient setting.
the outpatient setting? Yeah, so I mean, it depends on what exact situation are you referring to?
Let's say the person is already released to the community. So how do we know that those patients are adherent to the treatment?
Yeah, so that's a really good question. And so, I think that what the Help Act tries to do, and this was incorporated into the budget, is ensure that, frequently when someone is involuntarily hospitalized, it's usually they usually already have some sort of professional they were working with, whether it be a psychiatrist or a caseworker. What new changes in law would require is that there be greater coordination between the hospital and the professional the person was working with in the community, so that the hospital, as I said, informs that professional that they were discharged, involves them in discharge planning, gives them a discharge plan. And then, the budget also makes changes to ensure that if someone needs certain services that they weren't receiving in the community upon discharge, that they receive referrals, that hospitals, when they're discharging people, and try to schedule a follow-up upon discharging that person, that they make good efforts to be in contact with family members or other people that this person associates with, to inform them of the discharge, inform them of the plan. And I think that the answer is, I think the language in the budget, part of which was in the Help Act, is a good step forward to ensuring that when we're discharging people who are involuntarily hospitalized, they do actually get consistent help. I think part of this is there needs to be more funding for various professionals that, the state funds to provide outpatient assistance, which will be critical to this. And, the state's providing funding, they're struggling to get the contracts out, and that needs to continue. And then I think the second answer is we need to improve the standards even more. So hopefully that answered your question a bit.
Yeah, because the problem when they are released into the community, especially those that do not live with family members, so they're home alone, and if there's no any other staff that monitors, like on a daily basis, they can easily not adhere to those treatment, and the cycle goes back. They become better, they are hospitalized, they're released to the community, they become adherent to treatment, and then they go back again to the hospital. So it's just a cycle. So unless we do have a staff that goes to the home and observe them take the treatment on a daily basis, that would be the best way to monitor. Otherwise, we only say, oh, we have to make this discharge planning to make sure that they adhere, but do they really adhere to those treatment? That is a big question.
Yeah, no, I think that's exactly right. And I think that a lot of the teams that the state is funding, although they are designated for the most critical, serious situations, I think those teams will certainly, once they're fully staffed up and fully funded, will play an important role in ensuring at least the most serious cases do have a regular caseworker and point of contact to ensure that they're accessing benefits and receiving services and following treatment plans.
That's right. Otherwise, it's useless.
Sandy has a question.
Okay, so, so both of these acts have passed then, both the Support Act and the Help Act have passed?
So that's a good question. So what frequently happens in the budget is the governor and the Senate and the Assembly look at existing bills and grab language from existing bills and put them in budget bills that eventually pass. So that happened here, where language was grabbed from here and put in the budget. And we're pleased that part of this act, passed in a bill that was voted on yesterday to enact the mental health piece of budget policy. So the answer is budget bill is passed. That has a lot of good stuff on mental health. part of which is the HELP Act, if that clearly answers your question.
I guess, and so we no longer need to advocate for the Health Act because it's been, you feel all the parts that are necessary have been incorporated?
I think for the most part, yes. I'd say, we'd like to pass the HELP Act, but I think at this point, we're happy that the most important parts were passed in the budget. I'd say that, I shared the Support Act, yet another acronym. And I think that is our mental health priority for this session. And again, that ensures that when someone is deemed unfit to stand trial, in addition to simply having their case dismissed, and in addition to being referred to a hospital for 60 days, the hospital that then discharges them has to ensure that they receive further referrals for continuous care.
In our district, all of the hospitals, I mean, we have two major hospitals, they both are involved in this program.
Mhm.
NYU and Bellevue.
So it depends. I mean, I don't know exactly how sorry, was that a question or was that a statement?
That's a question, I really don't know the answer.
I mean, I would guess many hospitals in New York are involved in various degrees. But yeah, in short though, the way this works under the law is a court can order hospitalization for someone. And if it's going to be a psychiatric facility, I don't necessarily know what resources and facilities NYU or health and hospitals have specifically for that population in Community District 6, but certainly those resources exist in other parts of the city.
Elby, can you see hands raised, or
No,
what would you like us to do?
just
Shout?
Yeah, I cannot see anybody raising hands. I mean,
Oh, okay. Just a question, Evan, and I want to apologize for the question because I feel like it's not a fair question, but I'll ask it anyway, and you can decline to answer. But
Sure.
there's a massive cuts in federal spending for health and hospitals, and I'm told by people who work in health and hospitals that there's a freeze in hiring across entire health and hospitals. I'm not sure if this is like an existential crisis for city hospitals, the budget fall. How does that affect what you're trying to do here, and psychiatric care, psychiatric beds? And feel free not to answer the question because I feel like it's not a fair question, but I just want to put it out there.
Yeah, I think those are really important considerations. I guess, just shooting from the hip, I guess that when a hospital has more money, they're able to have more staff and they're able to have more beds. And I think that's what we all want. And yeah, I'd say my boss, Brad, and personally myself would want to see, especially hospitals that serve vulnerable populations, receive the funding they need to operate. So yeah, it seems like it certainly can help with mental health crises we're seeing in the city, that hospitals are in danger of being funded.
any other question?
I guess just to follow up, the Support Act would be our next one to take a look at and potentially support.
If that was a question at me, I think that's
Yeah.
what.
Sorry, yes, that's a question for you.
Okay, yeah, yes, I think that's what we'd encourage. So, this bill was authored in collaboration with DA Bragg, and so my boss, Senator Hoyman Siegel, carries it in the Senate, and Assemblymember Tony Simone carries it in the Assembly. And unfortunately, we only have a month or so left of the legislative session, given that this budget dragged on for way too long. But we're going to be pushing a lot for this bill, and at the very least, if we can't get it passed this year, we hope that something we can get passed further down the line, because I think everyone's acknowledged, all at least policy stakeholders have acknowledged that when someone is deemed unfit to stand trial, they should receive long-term help and not simply be released on the street.
Thank you.
Any other question? Brandon, is there anything? Because I can't really see.
I see no other hands raised. I see one hand raised.
New to this committee, Blair. Hi, thank you so much for sharing this. I'm just curious, as like a tactical thing, you're saying that this Support Act hasn't been passed and that's kind of the agenda. But I'm
Yeah.
curious why piece of the Health Act was incorporated into the budget and Support Act wasn't. And if that is something, thinking short-term, long-term, would that be a tactic for something similar to the Support Act, assuming that it may not go through in the next
Yeah.
month, like you said? Has there been any feedback about why that was?
Yeah.
uh,
Yeah.
allocated?
Yeah, so the HELP Act had a pretty long background in history. It was introduced last year. It had the backing of City Hall. City Hall had been circulating similar ideas for at least 2 to 3 years. So there was a basis for the bill, and it was a familiar idea when it came forward. The Support Act was introduced this year, and we definitely advocated for its inclusion in the budget, but I think rightfully so. It, folks, if something is a new proposal, folks want to give it a bit more time to try to go through the normal legislative process rather than include it in the budget. So I think that's my reasoning for why it wasn't included. But I think going forward, if it doesn't pass through the normal legislative process, yeah, I think certainly there's space for including it in the budget because a lot of policy is included in the budget. Hopefully that answers your question. And I think our goal, at least for this next month, would be to let this bill be better understood by our colleagues in the Senate, our colleagues in the Assembly, the governor's team, in order that if a new budget cycle comes around, it can be considered for inclusion, if not outright passing through the normal legislative process, if that answers your question.
And
I don't see any other questions in here.
No other question?
No,
All right, so thank you so much, Ever. That was a comprehensive explanation of the HELP Act. So hopefully we can review more of the bill that you showed us and we can ask more questions about it.
Great. All right. Well, yeah, thank you so much. And if you have any questions, I think Brendan has my email. All right. Take care, everyone.
Thank you. Thank you for coming.
Thank you.
Thank you.
And,
All right, so now. Oh,
sorry, Elby, just to interrupt, is this something that the committee wants to take up then, the Support Act? Is that something that you want to investigate further?
yes.
So maybe next month it becomes, if we look at it, it sounds like we don't have a lot of time to pass it through the legislature, but if it's something that we want to investigate,
Yes.
okay? Does someone wanna?
Sure.
Well, I definitely want to read it because I
Yes.
didn't know about it.
Yeah.
one thing I'll say is, June's health meeting would be after June's full board, so June 12th, so the committee can, because of the timing, especially in relation to the legislative session, the committee can sort of really look into this and write a good resolution if that's the direction the committee wants to go in.
Great, thank you.
That's good. Thank you. Okay, so now we'll go to the second topic in our agenda, which is a presentation by the NYU Langone Health on stroke awareness. And Dr. Jose Miguel Juarez is here to give us that presentation.
Hi, everybody. Thank you very much for this opportunity. I'm really grateful to be able to talk about stroke awareness. Before I begin, I have some slides. I'm happy to pull them up from my end, or do you know if somebody from your end might be able to pull up the slides?
Which would be easier for you?
I have them available here, so I'm happy to share my screen.
Okay.
Does
Yeah,
that
you should
work?
be able to share your screen.
Okay. Trying to find the sharing feature. Okay, great. Can everybody see my screen?
Yes.
Yes.
Yeah.
Okay, wonderful. Thank you. Once again, everybody, thank you so much for this brief time. Again, I'm really excited to have this time with you and and with our community to be able to share about the importance of being aware of stroke and how to respond to potential emergencies throughout the community. My name is Miguel. I am one of the NYU Emergency Department physicians, and if anybody has any questions along the way, please feel free to stop me. I'm happy to pause and answer any questions that you may have. First, I have no disclosures. I do want to give a very special shout out to the American Heart Association. They have a very comprehensive and a very great resource on their American Stroke Association website, which I will refer to throughout this presentation. They have resources for education, they have resources for the community, and also they have resources for families and also for any patient who may suffer from a stroke. So I really, at the end of this presentation, for anybody who's listening, I very much recommend checking out all of the resources that are available on the American Stroke Association website. So in this presentation, here are the objectives for today. By the end of the presentation, the audience will be able to discuss the definition of stroke, to talk about the potential impacts of stroke, the risk factors of stroke, signs of stroke, and be able to describe how to respond to a potential stroke in the community, as well as be able to describe the type of information that is useful to provide to emergency medical services, as well as the providers that will be taking care of the patient in the emergency department. To start, let's define stroke. Stroke is a neurologic emergency. I highlighted emergency because it's something that's very, very time sensitive. We have to be able to identify it very quickly in order to initiate treatments very quickly, with the hope of providing every patient with the best outcome possible. It's also known as a cerebrovascular incident, and essentially it is an interruption of blood flow to a part of the brain. This results in a lack of oxygen and nutrients to the part of the brain that is affected, resulting in brain cell death. And depending on the part of the brain that is impacted, a patient may suffer a specific neurologic deficit. There are two types of stroke. One of them is when a blood vessel is blocked by a clot. This is called an ischemic stroke. Or if the blood vessel ruptures, this is called a hemorrhagic stroke. This slide basically has a lot of information. The only reason I am including this is just to highlight the several different impacts that stroke can have depending on the part of the brain that is affected. For example, if the frontal lobe goes without oxygen or nutrients for some time, and if a patient suffers a stroke in this area, then a possible change may include changes in mood, changes in personality, difficulty with problem solving. On the other hand, if a patient suffers a stroke that involves the occipital lobe, this patient may suffer with long-term vision problems. If somebody suffers a stroke that involves the cerebellum, then these patients have difficulty with coordination and with walking. So as you can see here, there are several different parts of the brain that can be affected, several different functions neurological deficits that can result from whatever part of the brain is affected by a stroke. How common is stroke? Every 40 seconds, there's somebody in the United States that suffers a stroke. It's pretty common. Stroke right now is the 5th leading cause of death, and it is a leading cause of disability in the United States. And about 1 in 4 people who have suffered stroke end up having another stroke at some point. And in the time that it took me to present this slide, about 1 person in the United States suffered a stroke. Here are some risk factors for both ischemic and hemorrhagic stroke. With regards to ischemic stroke, patients who have uncontrolled high blood pressure, problems with cholesterol, uncontrolled diabetes, patients who smoke, patients who've had previous strokes. These are risk factors that are quite common among ischemic stroke. With regards to hemorrhagic stroke, people who have a history of brain aneurysms or issues with clotting or trauma patients can suffer from hemorrhagic stroke. As we discussed before, stroke can affect many different parts of the brain, and so because of that, stroke can present in many different ways. Stroke can present in very obvious ways, for example, weakness or numbness of one side of the body, or it could be very subtle, such as a speech change or difficulty speaking or understanding speech. A couple of other ways that it presents include the following: altered mental status, decreased level of responsiveness. Some patients can have a sudden severe headache. There are a lot of helpful mnemonics out there. I present one down here that's called BFAST, and it goes through several different neurologic symptoms that a patient can have who's suffering from a stroke. B stands for balance. Patients can have issues with walking, with coordination. E for eye. Patients can suffer from a visual disturbance in one eye or both eyes. F for face, facial droop, and facial sensory changes. A for arm, patients can have arm weakness, arm numbness. You can include leg here as well, leg weakness, leg numbness. S for speech, difficulty with understanding and with expressing oneself. And T, I really appreciate that they include T in this mnemonic, just because it's a really important reminder to everybody about the importance of immediately activating emergency medical services as soon as there is even the slightest suspicion of neurological deficit in somebody who may be having a stroke. I am really excited to include this slide. The American Heart Association stroke website has a really fun activity that is actually quite useful for anybody who wants to practice identifying different neurologic features that may be suggestive of stroke. So if you have some time, if you wanted to get some practice, definitely check out the site. It helps you go through the mnemonic that we just went through, and it's just a really good way of being able to practice identifying signs of stroke. So what if stroke is suspected? The most important step is to activate emergency medical services immediately. Even if you have the slightest suspicion, even if you're not sure at all, just still call. EMS has additional screening tools that they use to be able to risk stratify patients, and also to help them identify stroke and the need to notify the hospital. The great thing is that EMS is able to communicate quite closely and quite well with the hospital. So if there is a high suspicion for a stroke, then they can notify the hospital right away so that the hospital team can be ready to evaluate the patient. Some very important information that can be useful to provide the emergency medical services and also the hospital staff is what stroke symptoms were noted. Specifically, what new symptoms does the patient have that concerned the person enough to call EMS? Another really important bit of information is the last known well time, and what this means is when was a person last without symptoms? When was a person last well? Some patients can wake up with neurological deficits. In that case, the last known well time is when the patient fell asleep, because assuming that the patient fell asleep without any symptoms. Additional information that's important to provide includes a medication list. Specifically, it is important to know if the patient is on any blood thinners, because if the patient has a hemorrhagic stroke, then it will be important to reverse some of those blood thinners. Another important bit of information is the patient's past medical history. Has the patient ever had a stroke before? Does the patient have a recent history of trauma, of gastrointestinal bleeding? That information will be important for the hospital team if the patient will require IV medications in order to decide whether the patient can safely receive those medications or not. So what to expect when the patient arrives to the emergency department? The patient will immediately get assessed by an emergency department doctor. Vital signs will be obtained, blood sugar level will also be obtained. And if there is suspicion for stroke, then the stroke team will automatically be activated. And with this protocol, this is just really helpful with getting immediate CT imaging and reducing the time to treatment if treatment is indicated. Included down here is a table with times that emergency departments aim to meet with regards to how soon patients should be seen by emergency department doctors. So within 10 minutes, how soon the CT scan should occur, so within 25 minutes, and if IV medication, IV thrombolytic medication is needed, the time to administer that medication would be within 60 minutes. So as you can see, there are very strict time limits, and the sooner the patient gets to the emergency department, the sooner the patient gets diagnosed, the sooner the patient hopefully gets the treatment that they need, whether it be IV medications or whether it be mechanical retrieval in the operating room. In this slide, I present the different treatments for stroke. The treatment is really going to depend on the type of stroke, the timing of the stroke, and the severity of the stroke. To the left, we have ischemic stroke. So if patients arrive within 4.5 hours of the first symptom, and if they are candidates, then they may qualify for receiving thrombolytics. As you can see here, I highlighted 4.5 hours. This is why it's really important, the information that is provided to EMS and the medical team. They have to know when the patient was last well in order to know whether the patient is a candidate for this IV medication. Another possibility is a mechanical retrieval with a interventional procedure known as thrombectomy. For patients who have symptom onset within 6, sometimes within 24 hours, they may be candidates for a thrombectomy. So again, knowing the last known well time is extremely important for these patients. With regards to hemorrhagic stroke, some of the treatment includes controlling the blood pressure, reversing any blood thinning any medications that may be blood thinners, and also interventional procedures such as clipping or coiling of aneurysms or decompression if a patient is very sick. Going back to ischemic stroke and the IV treatment, this is the list that I alluded to before. I just really want to have everybody focus on the exclusion criteria here, specifically historical features that can be provided by community members or whoever called EMS. It's really important to know if the patient had any recent trauma, any recent gastrointestinal bleeding, because that is going to help determine whether the patient is a candidate for this IV medication. With regards to prognosis, every patient recovers differently. It really depends on a multitude of factors, and some of them are listed here. Very important is the time to diagnosis, the time to treatment, the severity of the stroke, and also the patient's past medical history. With regards to recovery, some recovery may be possible through several therapy options, which include physical, occupational, and speech therapy. What if symptoms resolve? This is a question that we get asked a lot. If symptoms resolved, then it's still concerning that they happened in the first place, because there's something that's known as a transient ischemic attack, which is a warning sign. Some people in the community call this a mini stroke. This is associated with a higher risk of stroke. So patients who have neurological symptoms that are initially concerning that resolve should still go to the emergency department for evaluation, for workup, and possible admission for further workup, as well as for control of whatever risk factors they have. For example, if they have uncontrolled blood pressure, uncontrolled high cholesterol, uncontrolled diabetes, this is a good opportunity to have these risk factors looked at and controlled. So some key takeaways. I would like everyone to go home with these points here. Stroke is common, especially among people with risk factors. Stroke can present in many different ways. There are a lot of great mnemonics out there. BFAST is one of the ones that I presented in this presentation. When stroke is suspected, even if there is slight suspicion, the slightest concern, still call 911 right away. There shouldn't be any hesitation. Remember, time lost is brain lost. If symptoms resolve, patients should still go to the emergency department for an evaluation. The sooner stroke is identified and the sooner treatment is initiated, this has been shown to lead to better stroke outcomes. And most importantly, it's just really important for everybody to know how important of a role we all have in being aware and in recognizing potential strokes, because we can all make a difference in the outcomes of these patients. A couple of interesting facts. In the time that it took me to deliver this presentation, 30 people in the United States suffered a stroke. And in this same time, a person suffering a stroke without treatment has lost 38 million brain cells. I want to thank everyone again. Thank you for your attention. Thank you for this opportunity. If anybody has any questions, I'm very happy to answer.
Miguel, I have a question.
Yes.
So how would you advise women when it comes to the sign and symptoms of stroke? Because women manifest different symptoms than men.
That's a very good point, and I think one of the most important thing for women, and also for anybody who may be living with anybody who's at high risk, is to just be aware of the seriousness of stroke, the serious impact that it could have if it is left undiagnosed and untreated. So it's really important for the community to not only be aware, but also to feel comfortable enough to activate EMS and to go to the emergency department for an evaluation. Even if the suspicion is very, very low, they still should be evaluated by a doctor who may be able to activate stroke protocol and hopefully diagnose obvious and subtle strokes as soon as possible with the protocols that we have in the emergency department.
Can you see if there's any?
Yeah, Vivian has a question.
Hi, doctor. Thank you for that incredibly informative presentation. I have a quick question. It seems like high blood pressure and diabetes or high blood sugar levels is a common reason for strokes. Is there something we can do preemptively, like on a weekly basis, to prevent that, such as taking a blood pressure like once a week, or checking our blood sugar levels, which these days we can do with so many apps and technological devices?
One of the things that I really want to highlight is just the importance of primary care. So my hope is that that everybody will be connected to a primary care doctor, because a lot of these issues require close monitoring, initiation of well, even before initiation of medications. There are a lot of modifications, healthcare, like lifestyle changes that patients can make in order to reduce the impact of diabetes, of high cholesterol. So my first recommendation is for everybody to for us to help one another and to connect the community with good primary healthcare. On an individual basis, it would be helpful for everybody to be aware of the importance of being conscious of your blood sugar levels, if you have a history of diabetes, and being able to the importance of taking your medications, as well as monitoring your blood pressure at home, and also the blood pressure of any other family members at home. So if the community is able to have a blood pressure monitor at home, that's a really good way of monitoring weekly blood pressure. And for anybody who has a history of diabetes or difficulty with controlling their sugar levels, having a blood sugar monitor at home would also be helpful.
Thank you.
Gloria has a question.
A couple questions. Thank you, doctor. One is, I'd be curious to know the age and gender stratification on the stroke data that exists. I don't know if there's a place you can recommend finding it. I'm sure you don't have it right there. But I'd be interested in that. And I also am really interested in any data, and I'm just wondering what you think about folks that have minor events and never seek care. That could be a really high percentage of folks, I imagine, who are not gonna go get care. So I'm just wondering, I'm really interested in some data around both those areas.
Those are both very great questions. And I was actually, in putting together this presentation, I was very surprised by how much information is available through the American Stroke Association's website. They have a lot of introductory materials, such as the material that was presented in this presentation. But for anybody who wants to learn more about the data, specifically about any of the stratifications that you had mentioned, there's a wealth of information in that site. Specifically, they refer to a lot of articles if anybody wants to look up more of the current research and the current information that is out there. So for data, one of the first places I would recommend is to check out the American Stroke Association site.
Thank you.
Mhm.
And I'm assuming nobody is looking at estimating how many people may potentially not show up in a medical facility who may have had a minor, especially people who don't have great healthcare and resources. But I'll look on that site and see if they may have data, but it's because you're really emphasizing how important it is to call EMS and make sure, even if it's minor, and transient to do so. So this is good information to get out to everybody. So thank you.
Thank you.
Any other question?
I don't see any other questions in here.
Okay, so thank you so much, Dr. Juarez, for doing this comprehensive presentation. And thank you also, Rebecca, for organizing this is a quarterly presentation from NYU Senate. Thank you so much. So we look forward to the next one probably in the fall, isn't it?
Yeah, because you're breaking for the summer, right? So thank you so much for having us. Yeah, thank you, Dr. Juarez, for doing this. I appreciate it. Thank you, everyone, for your questions and your engagement. And yeah, we'll set a date for the fall for the next one.
For the next one, yes. All right, thank you. Thank you for coming.
Thank you, everybody.
Thank you.
Thank you.
Okay, so we have the third topic in our agenda is the discussion on how to bring new healthcare facilities to Manhattan Community Board 6. So, Brandon, did you get the one that I sent you?
Yes, you sent me a document, which is the document I'm sharing.
Yeah, if
On
you can
screen
just
right
share
now.
that. So, I met with Sandy probably a few weeks ago, and we discussed about a topic about bringing a new healthcare facility that will provide service to the community, especially that the Beth Israel Hospital had closed already. So I have these that I look into how or what type of hospital we can think about to hospital that can provide service within our community. So I think we should look at a hospital, like a micro hospital that is of short-term acute care hospital that will focus directly in our community needs and that will operate within a compact clinical and administration framework. So this micro hospital will be licensed the same as the regular hospital. So that means that if Medicare reimbursement is sought, it is certified as a short-term acute care hospital. And the regulatory requirement for this micro hospital is the same as the regular hospital. So that means that there's no shortcuts when it comes to compliance, and is a realistic option for health systems seeking to address community needs in area where patients may have limited or overcrowded options, especially overcrowding our hospital within our community, like the Bellevue Hospital and NYU Hospital for acute or emergency care. So what are the characteristics of this micro hospital? This micro hospital can provide general services that include emergency, surgery, medical or surgical unit. That can also include laboratory and imaging and outpatient services. And the medical staff leaders or practitioners must be integrated into system-wide staff in larger hospitals. So that means that the medical staff that will man this micro hospital should be integrated with the other big hospital within our community, like the Bellevue Hospital, the NYU, the Veterans Hospital. Then the medical staff and chief medical officer must be governed and credentialed according to its medical staff bylaws and rules and regulations according to the minimum standards of the state agency for a hospital. And that the micro hospital can run from 2 to 40 beds, depending on state requirements to meet hospital standards and Medicare definitions of a hospital. And when it comes to the area, it can be from 75,000 to 25,000 to 75,000 square feet, but sizes must vary depending on the state-specific requirements for establishing hospitals. So these are characteristics of micro hospital in case we want a micro hospital that will serve within our community. So let's now open a discussion of these new healthcare facilities.
Elvie, are these temporary hospitals or permanent ones?
Well, this may be a permanent one, a micro hospital. It's a small hospital. It's a short-term acute care hospital. Again, that will focus directly on our community needs.
And do we know what our community needs are? Is there a way to determine that?
Oh, yes, definitely.
How would we determine that?
Well, we can determine that by, we can actually analyze what the Beth Israel has been serving us within this community. But it's gonna be the same services like emergency surgery, medical surgical unit. That can also include imaging services and outpatient services. It's not that that's what we need in our community in place of what we had from the Beth Israel.
Or we can look at population versus bed and facility and look at other areas that are well served and see where is the shortfall and how much is the shortfall. Because we want to do something that's gonna work and make sense, right?
And I just wonder where we get that data from.
I'm willing to search for it.
I'm
see
just
if we can
assuming,
find it.
doesn't each hospital already, like as Elvie said, a Better Israel can certainly opine on what they serve, right? What they major, but won't like NYU, for instance, they're serving this community. They're serving all of New York City, but a big chunk of their services in our district. Would they not be able to provide us that these are like, as they've done in a previous presentation, that these are the top reasons for why people in this district get ill? Like, for instance, they said heart disease is one of the #1 leading causes of issues for men, women, and children in our district. couldn't we get it from existing hospitals?
So does that mean it's a focus on what the emergency rooms provide?
I mean, it's
We
one,
can
that's only
understand.
one place to start.
This micro hospital will not replace the big hospital that we have. This will just alleviate
I see.
crowding since we don't have this Beth Israel hospital, so it overcrowds now like our Bellevue hospital, our NYU hospital. So this will just help alleviate, instead of them going to those big hospital, we have a micro hospital, which is a short-term care hospital that will focus on short-term services.
LV, who do you, when you kind of made this document, who do you vision financing this micro hospital? Do you envision like the city opening up a city hospital? Do you envision NYU opening up a satellite hospital? Do you envision another hospital system coming in and building a micro hospital right in the shadow of NYU to compete with NYU? Like, who do you envision that would finance this and set this up?
I'm envisioning the city to finance this.
Because the city is
doesn't
broke.
have- Yeah, city doesn't have funding to cover what it currently does.
Yeah, I mean, there
But
are
that's the
massive,
problem. Yeah,
massive
nowadays,
federal cuts.
yeah, because of the cuts. But who else do you think can provide this micro hospital?
And I think we're happy to have any one of those, is basically the answer. And I know, for instance, people have been reaching out to, Northwell because they are expanding their services in CB8 and CB8 feels that they're overbuilt. Now, will they want to come to this area? We don't know.
That's actually an interesting thought, though, to ask, they don't have a presence in our district, maybe they might want to open a satellite office.
And we understand that potentially NYU might be interested. as well.
right?
So I think one of the things that LB and I talked about is trying to understand what it is we need.
That's the
So-
most important thing.
Yeah, so that we can ask appropriate.
And part of that is not just based on beds and people, it's based on occupation of beds and people. What, occupation of how much services are done. So I am sure that data has to be available somewhere.
Well, I mean, since Beth Israel closed, they had to submit to the state health department what the statistics were, and I don't quite know
Wow.
how we
What
found that out, but. And I think, sorry, Albie, go ahead.
I think I'm thinking of this can be in collaboration with the health department, because they can reassign staff from the health department to man these micro hospital also. And we can also get staff from the other hospital like NYU and Beth Israel to collaborate with us in this micro hospital. But I'm more thinking about the health department. The city will provide more funding on this.
And it's one hospital, one micro hospital.
And the idea is that it would be where Beth Israel used to be.
Oh, okay.
Oh, in
Because,
that very same building, you mean?
well, again, the understanding is that the building needs extensive renovations.
Yeah.
And that right now, Beth Israel will sell the hospital to make money. So,
But they also have they had a huge presence, right, in the PACC building on 14th Street, the Phillips Ambulatory Care Center.
on the west side,
No, on the
They're
east
still-
side,
they're still
14th Street, yeah. But isn't that, I remember taking someone there a patient there to Beth Israel, but in that center.
It's outpatient, it's a huge
Okay,
outpatient center.
I see, I
14th
see.
and Union Square.
Now,
I just feel like it's a tough sell for Northwell to say, okay, Mount Sinai just failed there, lost $1 billion. But why don't you come in and give it a try? I mean, I'd love for them to do it. I just, wow, that is a big ask.
I think she's been.
Oh,
Some factors, to consider. In terms of physical location, you could think about mobile or some of the things that on the housing side of things that are being considered is transforming commercial space into resident space. So that could be an option here. Thinking more broadly, it could be pop-up, not necessarily a one entity size fits all for a micro hospital. For the public data, for the questions about data and like, how would we know what the needs are? When you mentioned Medicare, when you mentioned the health department and the competition between some of the hospitals you named, they might not be likely to bring data to you, but if you come from the framework of what public data you have, there are a lot of foundations that are associated with hospitals. They also have to comply with state, municipal and all that based on their funding. Most of it is grants. So the other element is capacity. There are the question of who would be the physicians, who would be the administrators. When you're talking about, I think you said earlier, sir, federal cuts, that's trickle down. So where does that come from? The staff. You could look into the same spaces for, well, if it's physical space that these hospitals cannot accommodate, you can actually utilize their staff under a contractual basis. So you're raising really great questions, but there are some probable solutions if you're looking outside the box and also what's already available, rather than recreating something completely new that also would be more demanding and the expectations are high that it might fail. And then that doesn't help necessarily the community urgency and the need, even in the short term. It could be on a trial basis. Like Evan, was it Evan earlier that was talking about the Support Act? It could be for expected 2026, 2027 period, which is also very attractive to private donors. I'm from the fundraising sector, so that's also something that we're not talking about right now, but in terms of finances, that is definitely something the philanthropic space is talking about and how to tap into those private enterprises, and that might also help the whole initiation of this. Just some things to consider.
I think a lot of the elected officials already run some, from time to time, some mobile pop-ups, right? Could we not expand on that notion? Since we are talking about reaching out to the city, which we know is in severe financial dire straits, but could we not expand on that? For instance, I know Rebecca Seawright or Alex Borges, et cetera, have had mobile vans that provide free, whether it's mammograms, what have you. Maybe we can start there with having all of the local council members engaging in some level within the districts.
And I think that it's not so much the mobile, it's the fact that the closest emergency room from Lower Manhattan
Yeah.
now is Bellevue.
Yeah,
And as they mentioned for strokes,
yeah.
time is of an essence, and so I think it's really more the emergency room type of facilities.
Urgent care, yeah.
That are important. I mean, absolutely, mobile is important, it's good. Actually, NYU, they said at that brochure, they do mobile services in Brooklyn, but not here. So.
Say that it's doubtful that a micro hospital of 40 beds can take care of strokes because you need a stroke team. So they would probably just transfer them to NYU.
But wouldn't
For
they
a stroke.
stabilize them and then? try to-
Yeah.
No, because time is of the essence, so you gotta get the TPA going, you have to get the treatment going, so they wouldn't even bring strokes to a
Anyway.
micro hospital. Yeah, they'd be on stroke diversion.
So who would they bring? Like, this is the question we have, like, what is good, is it? And is it
Accident
feasible?
victims,
Yeah.
assault victims, domestic violence victims. Who goes to emergency room? Well, any kind of acute illness that happens.
Well, sometimes even PCP related type.
Yeah,
Happens
yeah.
in the middle of the
acute thing
night.
that
you
happens
just
in the
find
night,
that.
you're gone. But I'm sorry, I'm a little bit of a data-driven person,
We need.
and I really wanna know what the need is
Yeah,
before we even come up, because great ideas, but if we don't know what the need is, we're spinning our wheels a little bit.
And, I mean, a lot of concern has come about the emergency room.
Yeah,
being
so that, yeah.
closed. And, you know, with congestion pricing, it's easier to get places, but it's still time driven. So what facilities could there be in this location that would help alleviate some of that? But it's true, we need some data. It's not, it's a very expensive thing, and it's not gonna happen unless we show them.
Yeah, and it's a great point you're making about data, and I think Bellevue is the prime thing to look into, like how
Yeah.
stressed is Bellevue? And I think extremely stressed because of funding cuts, right? I mean, so,
I spend a lot of time in a lot of hospitals in New York in my past career, the biotech industry, and Beth Israel was struggling a long time. And there's a lot of reasons for it. I was just reading briefly that, you know, this idea of the, oh my God, monetary, like making money in medicine, like a lot of these hospitals are in the red. Like that's a normal thing to be in the red. So I think we want to see like really the details, what happened there, what was going on, and who were they serving up till the end, like when they decided they were shutting their doors. Because I don't think we really know still, even with everything.
I mean, I think there's all kinds of numbers available. There was one that I saw that they looked at the, you know, the zip codes of people. And actually, it was interesting that Mount Sinai Beth Israel served zip codes all over the city because it was people who worked
Oh, yeah, in the area.
would go. And there's also, you know, they took away the maternity section, which apparently is a way to make money.
Yeah.
But they took it out of there.
Yeah.
We don't know why.
And when Spark shows up with all those new people.
Yeah.
to the
I mean,
area.
it has left a massive void, right? As it is currently, it's hard to get, you know, specialist appointments anyway. There's such an acute shortage, it seems, of healthcare technicians, and to have
It's gonna get
a massive
worse.
hospital shut down.
And one of the things that LB pointed out when we were talking is vaccinations. There isn't really a place to do it anymore in Manhattan. You have to go to Brooklyn.
Wait, can you not just go to your pharmacy?
Well, if you,
No,
you know, some vaccinations.
well,
So,
there are changes into the vaccination requirements, like children below 18 can no longer get their vaccination from the pharmacy. They can
Really?
only go to the health department.
Oh,
Yeah. So
That is a problem.
so I think, the board is going to look to this committee to try and find out some of this information because, you know, Beth Israel has closed. The site will be sold. And if we want to make sure that we have some say in what's built there, we really do, we need to know what we want. So,
I'm more than happy to try to track down the report to the health department from them with any statistics we can find. Because I guess you're saying they had to give some kind of report on closing. So let's get that to start at least. And then maybe see what are the other shortfalls.
Yeah, and I'll add that if there's any data you all are looking for that you're having trouble finding from like the health department or health and hospitals, let the office know and we can ask our contacts at the health department at health and hospitals to see if they might have that data somewhere and can give it to us.
and actually, the land use waterfront committee has a task, you know, a separate sort of subcommittee where they're looking at the site. And if someone from this committee would be willing to join them, there's a lot of discussion about this, about a micro hospital. And there is a coalition that's been looking at Mount Sinai Beth Israel closure for, you know, a couple of years now. So there's a lot of data available. It's sort of knowing what we want,
Yeah. Mhm.
but
so we can continue this discussion in the next meeting again, because this is a complex one. It's not an easy
Yes.
one that can be resolved in one meeting. So we can continue. First, we need to get those data, if we can, from the health department. And we can also probably request some data from Bellevue Hospital.
Actually, that would be interesting.
Do you think any of the electeds would have that information too? Especially the ones who've been vocal
Involved,
about
yeah.
MSBI
Could be.
closing.
We're asking the coalition for information, but if there are very specific items that we can identify, that's much easier.
Okay.
And Senator Gonzalez's office attends the coalition meetings, so
So they're included.
they're involved, yes.
That is prime real estate for
I
like
think-
a nice high rise and, you know,
It's on the park.
yeah, it's perfect. It's unbelievable
Yeah,
real
yeah,
estate
yeah,
right
yeah.
there. That's the problem.
For low income housing, right?
Yeah.
I'm saying
Affordable.
affordable.
All
Affordable is relative.
In our dreams, Miriam.
Huh?
Our dreams, Miriam.
That's
We
what we're
try.
asking for,
You have
But
to.
Yeah,
of course.
Yeah.
So,
but I think we probably need to get some actionable items, right? So
Yeah.
one is to get this data.
right.
um,
All right, so if anybody can take the lead in getting this data, so we can have it presented in the next meeting.
And at least if someone puts together a list of what we need, we can, share resources. Rupal has been going to the meetings, to the coalition meetings. So if we know exactly what we want, we can ask.
Okay, so the next agenda topic is about discussion of the statement, district needs and budget request. If you have any other ideas about needs that we have in the health and environmental that we can include in the budget, please feel free to say so.
And Brendan, this is the city budget, right?
Yes,
For our city agencies.
yes, this is city level.
And has everyone looked at the district needs statement?
I did briefly.
I
before I
glanced
came.
at
Yeah, if you'd like, Laura, I can share it with you again, since I know you're the newest member of this committee.
So no other ideas for,
Not yet.
and Obi, have you looked at the district needs statement?
Yes.
So it's,
When was the last time that, remember I sent you, something.
okay, so that's that's what we're,
That was, yeah.
okay, thank you.
Brendan, you have that, isn't it?
Yes.
But if anybody else has, some suggestion, yeah. Or we can still include that, Brendan, we can include that in our next agenda topic. Continuation of the discussion of statement of district needs.
If everybody's read it and they're comfortable with it, we don't need to discuss it again, but. Okay. I need to go back to it.
Okay, so we're gonna go to, I do not have anything to report. I just wanna I wanna welcome Gloria. Gloria is now part of the Health and Environmental Committee.
Thank you. Happy to be here.
Parks and History also here.
Yeah.
So congratulations, welcome.
I sadly left Parks. I loved that group. I really did.
Why did you leave?
Yeah, it's scheduling conflicts, and this is an area I know quite a lot about, so I thought it might be helpful.
And Kat is actually a new member of the board who's here. this
Welcome.
week.
Welcome.
Welcome. Congratulations.
Oh, I can't see her face.
Yeah, no.
Oh, okay, so welcome to this committee.
So you'll be at full board, when is next week? Yes. Great. We have 8 new members of the board, so.
Very
That's
nice.
amazing.
Cool. We'll meet them all next week.
Very nice.
Okay.
I'm gonna be traveling to Philippines in June, July, and because I have a project in the Philippines, so Rupal is taking over. Although most of the time in the summer, we don't really hold a meeting like July and August. So we resume in September. But Rupal is gonna take over while I'm away. She's taking the position. Okay, and hoping to see you all in September.
Likewise,
Happy travels.
safe travels.
Thank you.
Thank you.
Okay, so any other new business?
Motion to adjourn.
So there's no any old or new business. We can adjourn this meeting at 7:55 p.m. And thank you everyone for coming.
Thank you, Elvie.
Good night.
If you don't see you, safe travels.
Thank you.